So next we'll have Dr. Tam Huynh, Houstonian, talk to us about visceral artery aneurysms. Thanks, Tam.
Great talk, Dr. Robinson. I'm Tam Huynh. I work at the University of Texas MD Anderson Cancer Center. And I believe you actually had a talk about visceral artery aneurysm already yesterday. So it's a little bit repetitive, but it's like most things in life or surgery. Repetition and practice makes it perfect. So my assignment is to talk about the management of visceral artery aneurysm. And this is a rare entity, although it can be potentially very catastrophic. It is rare. The incidence is estimated to be somewhere between 0.01 to 0.2%. And most of these are really found asymptomatic on incidental imaging studies. The pathogenesis and natural history is really not well known. And the key about this is that when it ruptures, it is associated with high mortality. So I'm going to talk about the management like most things in vascular surgery. It's either surveillance, endovascular, or open surgical. And I would say I've been in practice now for 15 years, and I have yet to see a ruptured splenic artery aneurysm. And I would say for every operative, for every time I intervene on a visceral artery aneurysm, I would surveil probably about 20 to 1. So it's really not a very common thing that we do, but it's something that you get on exams a lot of the times, you know, these esoteric stuff. So it's good to sort of read about it. But you've heard from Dr. Mitchell yesterday, I think the most common lesion is the splenic artery aneurysm. That's sort of about 60% of all visceral artery aneurysm occur in the splenic. And then followed by the common hepatic as the second most common. And then the other ones include lesions in the SMA or celiac or some of the smaller branches. Renal artery aneurysm is sort of tend to be lumped separately than the visceral artery aneurysm, but the renal artery aneurysm is also not very common, and I think Dr. Mitchell talked to you about that yesterday. So the etiology, so it's thought that these are usually just like your typical aneurysm is due to acquired medial degeneration. Rarely you'll see it in people with Ehlers-Danlos, and then spontaneous dissection can lead to aneurysmal formation as well in these visceral artery segments. And then the pseudoaneurysm, which is really totally different. The acute pseudoaneurysm is typically due to traumatic, gunshot wound, blunt trauma, or postoperative surgery is probably the most common cause of pseudoaneurysm of the visceral arteries. And then infectious is the other cause, and these tend to be post-op as well. So splenic artery aneurysm, again, is the most common type of all visceral artery aneurysm. It is also associated with formation of aneurysm elsewhere in the abdominal, and thought to be associated with 14% of concomitant renal artery aneurysm as well. The thing to note is that this is one of the few things that is more common in women and men, and if it occurs in people in age of potentially being pregnant, then it is important to consider repair or resection or exclusion of these splenic artery aneurysms. And really less than 5% of these will present as a rupture aneurysm. As I said, I have yet to see one. But you will see one that is diagnosed incidentally, more common than not. It is typically asymptomatic, and as I mentioned, you would treat it if it's symptomatic or in childbearing women, childbearing age women. The other indication for fixing splenic artery aneurysm is people who have had orthotopic liver transplant, because it's thought that it has a high risk of rupture in that patient population. And I think most people would agree if it's greater than 3 centimeters, then it is probably reasonable to go ahead and think about fixing it. What remains controversial is whether the peripheral calcification or whether the finding of thrombus within the aneurysm is protective. I would say that it probably is not protective if the size is large. So there's many ways of treating the splenic artery aneurysm. You can treat it surgically, you can treat it endovascular. Kind of really depends on the anatomy of it, right? So, but the underlying sort of principle is that you really try and save the spleen for its immune sort of role. So endovascular technique include coil embolization and Stent-Graft, and I'll show you a couple of cases. The open surgery remains an option, and I'll show you a couple of cases about that too. And then laparoscopic surgery, for those of us that may have more advanced laparoscopic skills, is also a reasonable option to treat these splenic artery aneurysm if the anatomy is suitable. So this is an example of coiling of the splenic artery aneurysm. So the best type of aneurysm that you can coil would be one with a long, narrow neck, and this is such a thing. You see, this is a large splenic artery aneurysm with a kind of narrow neck, narrow, long neck, and you can see that it's obliterated with lots of coils. Here, you'll have to take my, you have to believe me for this, but this patient actually had a 3 centimeter splenic artery aneurysm 5 years ago. And this is her follow-up CT scan showing that the cover stent that we placed inside the aneurysm has completely excluded the aneurysm, and it is now completely without flow and shrink. This is a case of a patient who actually was found to have concomitant pancreatic cancer as well as a large incidental splenic artery aneurysm, and you can see this is the aorta, and that's actually the large splenic artery aneurysm. So we were going to actually fix him at MD Anderson, and we first attempted to try and put a cover stent, but you can see the challenge about these splenic artery aneurysm is that the splenic artery tends to be very tortuous, and it's hard to get good purchase to actually put a cover stent in it. And so we attempted but couldn't really navigate a stent across this thing, and because we were a little hesitant to try and do a combined splenic artery aneurysm repair and Whipple, the patient actually went to Johns Hopkins and had surgery there. But this is his reconstruction. So at the time of the Whipple, they actually went ahead and opened the aneurysm and fixed it and brought the two ends of the splenic artery back together in an end-to-end reconstruction, and you can see the splenic artery reconstructed post-op here. This is a second most common location for a visceral artery aneurysm, and that is located in the common hepatic artery. It happens almost as evenly between men and women. It tends to occur in older people, and it's also associated with other areas of aneurysmal formation in other arteries. 80% of these will be in the extrahepatic, common hepatic, or right or left hepatic artery. These arteries tend to be small, so putting a cover stent in would be difficult. But the common hepatic is probably the only hepatic artery that you can put a cover stent in, because the right and the left tend to be a little too small for that. Something to remember is called Quincke's triad, and this is associated with rupture hepatic artery aneurysm into the biliary system, and they present with abdominal pain, jaundice, and hemophilia. Quincke's triad. So hepatic artery aneurysm, again, is rare. Typically, we don't fix it until it gets bigger than 2 or 3 centimeters. Definitely fix it if you think it's a pseudoaneurysm. You know, when these present as an incidental finding with no symptom, it is hard to know whether this is a pseudoaneurysm versus a true aneurysm. The only time you can tell for sure it's an acute pseudoaneurysm where you have previous CT showing a completely normal artery, and then the following CT show, a pseudoaneurysm. But other than that, it is actually hard to know for sure whether an incidental finding is a true aneurysm versus a pseudoaneurysm. These also rarely can form fistula to the portal vein, and these, that would be an indication for fixing, obviously. So treatment of hepatic artery aneurysm, if it's intrahepatic, then typically this is sort of an area where the interventional radiologists would have more experience than we do, putting coil in or glue into those intrahepatic aneurysm. The extrahepatic artery aneurysm, typically open surgery if the vessel doesn't have the good anatomy for putting a cover stent. This is an example of a common hepatic artery aneurysm. You see its location right here in a patient that actually had a sigmoid cancer and a common hepatic artery aneurysm, so we were going to do the procedure at the same time. So I went in first, fixed the common hepatic artery, but it was actually, it's a tough location, and we we fix it by opening the aneurysm and putting a saphenous vein graft into position. And you see this is a completion CT a few months later. You see the vein graft from the proximal common hepatic artery to the distal hepatic artery with the saphenous vein graft, jump graft there. Pseudoaneurysm of the common hepatic artery. This is not an uncommon finding for people post-op. This first patient had a Whipple procedure and developed common hepatic artery pseudoaneurysm. Here you can see the pseudo and the hematoma. And these typically can be treated with endovascular means. This is a selective arteriogram of the common hepatic artery. You see the pseudoaneurysm here, what came from below, and you see that you see these are drains placed postoperatively, and you see the coils that we put into the pseudoaneurysm. So pseudoaneurysm, typically we can treat these with endovascular coiling of the common hepatic artery. The third most common visceral artery aneurysm is involved the superior mesenteric artery. It is the indication to treat, again, if it's greater than 2 to 3 centimeters. I have tended to be a little bit more conservative. I don't treat until it gets above 3. The symptoms are rare, but on occasion they can have some abdominal pain. And treatment of it is really, again, depends on whether you have good proximal and distal neck to place a Stent-Graft. If not, then a open surgery is the way to do it. This is a patient who developed an aneurysm after acute spontaneous SMA dissection. You can see here the aorta, the SMA there, and you can see the dissection with the aneurysm. And the aneurysm is still relatively small, so we're keeping an eye on that. This is another patient post-Whipple procedure, and you see air in the biliary tree. And this is a post-Whipple SMA pseudoaneurysm. Let's see how you would want to treat this one. So again, you know, that's the aorta there. You see that's the celiac. And this is the SMA right over here. See the pseudoaneurysm right here. Not a lot of bleeding around it, but you can sort of see the pseudoaneurysm. So remember, pseudoaneurysm don't really heal. They need to be fixed. I'm not quite over time yet.
I took some of your time.
You took some of my time, but I have 20 seconds. Okay, here. Let me just close up. Let's see. So for that case, we actually were able to put a cover stent in it. And how did I go to, you can't magnify, huh? Here, anyways, let me show you. So we were able to, you see that pseudoaneurysm right there. Now we'll go to the next slide. Go here. And so because the SMA at this segment, it's large enough that you can fit in a 5 millimeter cover stent. And we used a Vibon at the time. The balloon expandable Vibon were not available just yet back then. But, oh, well, thank you. So that's the pseudoaneurysm. This is the SMA stent. You know, the problem with the SMA is that it does go into spasm quite a bit, and you can see at the distal edge of the stent, there's fairly significant spasm. So celiac artery aneurysm, I find the celiac axis is very short. It is very hard to actually do any bypass to it or even putting a stent in. And so typically you would have to exclude it and you would do a common hepatic artery bypass rather than fixing the celiac artery aneurysm itself because the artery itself is way too short. Any other branches inside the belly can form aneurysm. They could be pseudoaneurysm or they could be true aneurysm. And it's thought that the risk may be high for rupture, but I'm going to show you this one last case. This is a patient that sort of actually still being worked up, but this is her CT scan just a few months ago, and you can see the big kidney cyst there, and you see the inferior pancreatic coduodenal aneurysm. And if I have any Galveston fellow in here, she's actually from Galveston, and she came to us because she actually was treated for lymphoma over 15 years ago. And we're lucky that we actually have all the CT imaging on our system. And this is her CT back in 2000 when she was treated for lymphoma. And you can actually see that inferior pancreatical duodenal aneurysm actually was there, and it hasn't really changed very much. So 17 years of it. So it went from like 1.6 to like maybe 1.9 centimeters. So even though people say that, you know, you got to treat all of these because it's thought to be high-risk rupture, we've actually have some patients that the natural history tells us that it may not be as aggressive as we think it is. So I'm going to close up. Visceral artery aneurysms are rare. The management, I think, should be expectant if they have no symptoms and if it's not a pseudoaneurysm. So pseudoaneurysm is a different thing. You've got to treat all acute pseudoaneurysms. And open and endovascular treatments are satisfactory and acceptable for anybody with symptomatic or aneurysm greater than 3 centimeters. Thank you very much.
Thanks, Tam. That was a great talk. I think it's worth, just kind of mentioning to you guys for these kind of things. Keep an eye on what's coming out of the Low Frequency Disease Consortium that I believe Dr. Lawrence has started and now, has a lot of national collaborators because, we have all these textbook indications. I mean, Tam alluded to this, textbook indications for size of repair, and, we don't, that's basically, we don't have a lot of natural history information. So this low frequency disease consortium is sort of doing that. So I think it's fair to say that like our thresholds for repair in these things is a little bit of a moving target right now. It's really kind of hard to know exactly where things are. I mean, when you're answering questions and sort of talking to patients, it's probably still right to stick with the textbook indications, but there'll be a lot of people who think that that's a little too aggressive. Thank you very much.